So, good evening, everyone. So, good evening, all the faculties and esteemed delegates to join today's webinar. So, it's a great pleasure to welcome you all ASCO Updates 2026 Day 2. And I would like to invite Dr. Sumit Goel, sir, for the opening remarks. And he's a Associate Director, Medical Oncology, Rajiv Gandhi Institute and Research Center, Delhi. So, it's over to you, sir.
Good evening, everyone. Thank you very much, dear colleagues who are joining today. Yesterday, we had a wonderful session, and it was uh, wonderful discussions happened yesterday. I'm sure the same thing will continue today again. So we have wonderful faculty, a learned faculty, and a faculty with experience who can not only contribute academically but from their personal experience also. So we have Dr. Rajiv Seni from Jammu, we have Dr. Abhishek Anand from Patna, we have Dr. Vikas Salreja from Kanpur, and we have dynamic Dr. Shefali Sardana from Delhi. So not and Dr. Jatin will be joining from Chandigarh. And we have as panelists Dr. Venkat Babu, Dr. Vikas, Dr. Divesh, Dr. Shefali, and Dr. Nikhil. So not taking much of time. So today's session is on GI cancers and HCC. So first session is by Dr. Rajiv Seni. He will be talking on Metron study. So Dr. Rajiv, over to you for your presentation.
Thank you, sir. Good evening, everyone. Thanks, Dr. Sumit sir and organizer for giving me opportunity to discuss about Metron trial, and this is first session of this day. So let me share my slides. So are my slides are visible?
Yes, sir. Make it full screen, please.
Okay. Okay. So our slides are moving.
Yeah, I think the slides, we can see the slides full screen.
But I think slides are not moving from my sides.
Yeah, they are not moving.
Let me share again.
Hmm. Yeah, they are moving now.
Okay. So today we are going to discuss about Metahunt trial. So we have seen evolution of treatment in this setting, that is resectable gastric cancer, from adjuvant chemo radiation to perioperative DCF to perioperative FLOT, and now immunotherapy has also come in this phase, in this setting also. Now this is a phase 3 randomized double-blind placebo-controlled global trial to evaluate the efficacy and safety of neoadjuvant durvalumab in combination with FLOT in patients with resectable gastric cancer and gastric esophageal junction cancer. So regarding the design of this trial, they have enrolled patients who are histologically documented resectable stage 2, 3 or 4A gastric cancer with T2 N0 to 3, T0 to T4 to N1 to N3 with no evidence of metastasis, no previously treated with anti-cancer therapy. And they are upfront resectable with performance state of 0 to 1. So around 900 odd patients were randomized in 1:1 ratio to experimental arm, which was durvalumab plus flot, versus control arm, which was flot plus placebo. So in before surgery, they have given 2 cycle of flot on day 1 and day 50 with 4 weekly durvalumab. And after completion of 2 cycle of flot plus durvalumab, the patient have gone to surgery after 4 to 8 week of completion of treatment. Then after 4 to 12 week of surgery, then patients have received adjuvant therapy. Uh, Again, 2 cycle of flot in adjuvant setting along with durvalumab, which was given for a period of 1 year. In control arm, flot was given for 2 cycles with placebo for 1 year. So primary endpoint in this study was event-free survival, and key secondary endpoint was overall survival, pathological complete response, safety, and tolerability. And the patient was stratified on the basis of geographical region, lymph node positivity, and PDL1 expression. So regarding the treatment disposition, almost all the patient has received neoadjuvant treatment, and around 96 or more than 95% of patient has completed neoadjuvant flot, and around more than 95% patient has completed neoadjuvant durvalumab also, and around 80 more than 85% of patient has completed surgery, and more than 90% patient has R0 resection in those who has completed surgery. And if we talk about the adjuvant treatment, around 75% of patients in both the arm have received adjuvant treatment, and around 50% of patients has completed durvalumab arm in durvalumab and placebo in respective arms, and flot was completed in around 60% of patients. Regarding the baseline demographics, they were well matched in both the arms, and there are a few points which I want to highlight. That is, around 2/3 of patients who have gastric origin, while 1/3 have a gastroesophageal junction, and around 1/4 of patients have T4, have T4, and around 70% of the patients were node positive. And if we see regarding the PDL expression, it is more than 1% in 90% of the patients. So coming to the primary endpoint, that is event-free survival, we can clearly see that this is the first interim analysis of this trial, and in interim analysis, the median EFS in flot arm has reached around 32.8 months, while it has not reached in the durvalumab arm. And at 2 years, there are absolute benefit of around 9% in durvalumab arm. So this addition of durvalumab significantly improved EFS versus perioperative flot alone. Regarding the subgroup analysis also, majority of the subgroup has shown benefit with the addition of durvalumab. And regarding the final overall survival, it is yet to mature because it has not reached, median OS has not reached. But if we look at 3 year, it is the absolute benefit delta is 6.7 in favor of durvalumab. So again, OS in key subgroups, it is again, you can clearly see that majority of the subgroup has is in favor of addition of durvalumab. Regarding the PDL1 status, OS was improved with durvalumab plus flot versus placebo, regardless of PDL1 status. In those patients where the TAF was more than 1%, there was clearly difference into the in between the two arms. Similarly, in less than 1% also, there was clear separation of both the arms. So the addition of durvalumab was seen irrespective of PDL1 status. Regarding pathological complete response, there is only 7% PCR in flot alone arm, while it is 19% in with the addition of durvalumab in with flot. So the absolute benefit of around 12% was seen. Regarding the response, any response, whether there was complete pathological complete response or major pathological response or any pathological response, the EFS was improved with durvalumab with any degree of pathological response seen. So regarding the treatment delivery, majority of the patient in both the arms have received similar type of treatment, and the addition of durvalumab did not affect administration of chemotherapy. Regarding safety profile of for durvalumab plus FLOT was consistent with the known safety profile for each individual agents. And if we look at the adverse effect, majority of the adverse effects are because of chemotherapy arm rather than the addition of durvalumab. So with the addition of durvalumab, there was no new side effects were seen. Only the immunotherapy related side effects were slightly increased. So the key takeaway from this study was that immunotherapy durvalumab was at present durvalumab was only immunotherapy which has significantly improved EFS as well as OS compared to placebo plus FLOT in resectable gastric and GAG adenocarcinoma, and the benefit was consistent across subgroups, and there was no safety concern seen. Profile aligned with non-durvalumab and FLOT toxicity were seen, and there was no decrease in the number of surgeries seen with the addition of durvalumab. Thank you, and back to the organizers.
Thank you, Dr. Rajiv, for your wonderful presentation. I'm sure Dr. Jatin is going to ask you questions. So just quickly, so have you changed your practice based on this, or are you thinking of changing the practice based on this?
Basically, the question in Indian setting is finances. If the
Correct.
finance is not a problem, I think we should give patient benefit, because from last many years we were very clear that whenever we have given the patient the best treatment at present, the maximum
Mhm.
benefit was seen. Because majority, as we have seen in this trial also, that adjuvant treatment only 70% of patients has completed adjuvant treatment, and only 50% of patients has completed chemotherapy in adjuvant setting. So the addition of durvalumab, if we have a good immunotherapy, good drug in neoadjuvant setting, in addition to what is existing, and that has shown consistent benefit across all subgroup, then these should be added.
Yeah. Thank you very much. I fully agree with you. Given a choice, finances are a big barrier for us all. Given an opportunity, definitely we would like to give our patients the best of treatment which is available as of today. So thank you very much, Dr. Rajiv, for your presentation. So moving on, we have Dr. Abhishek Anand from Patna. Dr. Abhishek will be speaking on SCC on Checkmate 90W study. So Dr. Abhishek, over to you.
A very good evening to all of you, and thank you, organizers. Thank you so much, sir, for the opportunity. So, I will be presenting the abstract on nivolumab plus ipilimumab versus lenvatinib or sorafenib as first-line treatment for unresectable hepatocellular carcinoma. This is the 4-year follow-up of Checkmate 9DW trial. So the key takeaways for this trial was that at the 4-year follow-up of this Checkmate 9DW, Nivo EP continued to show sustained efficacy benefit versus the TKI, lenvatinib or sorafenib in previously untreated patients with unresectable HCC. So we have multiple options now for unresectable hepatocellular carcinoma, especially for the immune checkpoint inhibitors, and this Nivo EP is one of those options as well. That has shown longer median overall survival with higher 24, 36, 48 months overall survival rates, clinically meaningful overall response rate benefit as compared to the conventional TKI, that is lenvatinib or sorafenib, with a higher complete response rate and a durable response as well. The safety of Nivo plus EP was manageable with no new safety signals reported with the longer follow-up. These results continue to support Nivo EP as the first line standard of care for patients with unresectable hepatocellular carcinoma. Coming to the study design, this was a global phase 3 randomized open label trial. The key eligibility criteria being unresectable hepatocellular carcinoma that has at least one measurable lesion, systemic therapy naive, child PUG A only, that was either 5 or 6 in number, ECOG performance status of 0 and 1, no main portal vein invasion, that is VP4 was not included in this trial. Randomization 1:1 to receive either Nivo plus EP. So dose here was Nivo 1 milligram per kg and EP dose was 3 milligram per kg given every 3 weeks up to 4 cycles, and it was followed by Nivo maintenance of 480 milligram given every 4 weekly. It was compared with the investigator's choice of either lenvatinib, which was given at the dose of 8 milligram or 12 milligram, depending on the body weight, and or sorafenib given 400 milligram twice a day. The primary endpoint of this study was overall survival, and the key secondary endpoint being the overall response rate and duration of response, as well as time to symptom deterioration. If you see the baseline characteristics, the two arms were more or less well matched between the two were well matched. And if you see the etiology wise, hepatitis B and hepatitis C were 60% in the Nivo EP arm, and it was around 65% in the lenvatinib and sorafenib arm. So almost 60 to 65% of the patients enrolled in the study were having a viral etiology. So as we know that viral etiology patients along with the CLD usually respond better with the immune checkpoint inhibitors. BCLC stage wise, BCLC-C was 73% in the Nivo EP arm, and it was also 73% only in the lenvatinib sorafenib arm. Alpha fetoprotein wise, more than 400 nanogram per ml, it was 32% in the Nivo AP arm and 34% in the Lenva sorafenib arm. And alpha fetoprotein usually tells us about whether the patient is high risk or low risk. If the patient is having alpha fetoprotein of more than 400, it is considered to be high risk patients. Coming to the results, the primary endpoint, which was overall survival, it was better for patients who were enrolled in the Nivo EP arm. The median OS was 23.7 months in the Nivo EP, and it was 20.6 months in the lenvatinib plus sorafenib arm. Also, if you see the 24-month rate, it was 50 versus 39%, 36-month OS rate 39% versus 25%, and 48-month OS rate was 31% versus 18%. So Nivo EP continued to do better in terms of overall survival as compared to lenvatinib or sorafenib arm. Response wise, the overall response rate was 36% as compared to 13% only in favor of the Nivo EP arm. Also, if you see the complete response rate, that was 8% in the Nivo EP arm, and it was only 2% in the Lenva sorafenib TKI arm. Another important thing is that median duration of response, it was 34 months in the patients who were enrolled in the Nivo AP arm, and it was only 12.9 months in the TKI arm. So it was more than double. The median duration of response was more than double in the Nivo EP arm as compared to the TKI. So there was a sustained OS benefit with Nivo EP and continued overall response rate benefit with the Nivo EP as compared to the TKI, that being either sorafenib or lenvatinib. Safety summaries wise, any treatment emergent adverse events were seen in 83% of the patient in Nivo EP arm, that was of any grade, and grade 3-4 toxicity was seen in 41% of the patient who were enrolled in the Nivo EP arm. And in the lenvatinib sorafenib arm, it was 91% that was any grade toxicity, and 42% that was of grade 3 and grade 4 toxicity. Safety was consistent with previous follow-up with no new safety signals. The treatment related adverse events occurring in more than 10% of the patients in Nivo EP arm were mostly diarrhea, pruritus, hypothyroidism, rash, decrease, increase in the liver enzymes AST and ALT, asthenia, then fatigue, lipase increase, and hyperthyroidism. So these were common toxicity which were seen in the Nivo EP arm. And when we talk about the TKI, Lenva or sorafenib arm, it was hypertension, then diarrhea, PPE syndrome, that is hand-foot syndrome, and then hypothyroidism, decreased appetite. So more or less it were associated with the VEGF inhibitions. Immune-mediated hepatitis with Nivo plus EP. Median time to onset of any grade immune-mediated hepatitis was 6 weeks, and these events resolved in almost 75% of the patients, with a median time to resolution being 10.3 weeks. 17% of the patients also received high dose steroids for this immune mediated hepatitis. So this continued to be manageable using established algorithm, and most did not result in treatment discontinuation. To summarize this CheckMate 9DW trial, after 4-year follow-up, Nivo EP continued to show sustained efficacy benefit as compared to the TKI, lenvatinib or sorafenib in patients with unresectable hepatocellular carcinoma with a longer median OS and a higher OS rate at 1 year, 36 months, and 48 months. Continued objective response rate benefit was seen with a higher complete response rate and the duration of response, which was more than double for Nivo EP arm as compared to the lenvatinib or sorafenib arm. The safety of Nivo EP was manageable with no new signal reported with longer follow-up. Hepatitis, that is immune mediated hepatitis, continued to be manageable using established algorithm, and most did not result in treatment discontinuation. These results continue to support Nivo EP as first line standard of care for patients who are having unresectable hepatocellular carcinoma. So these are the acknowledgements. With this, I would like to conclude. Thank you. Thank you, organizers.
Thank you, Dr. Abhishek, for your wonderful presentation. So, as Dr. Raji said earlier, in our area, in our country, we are the most barrier for us is basically the finances. So now we have three IO regimes in a first line setting. One is IO-VEGF, atezolizumab, then we have durvalumab, and we now have this combination nivo. So how you will be choosing and what percentage of your patients in your practice are likely to take this IO dual IO combination?
So basically, we have to select the patients based on the toxicity profile of these agents. When we talk about atezo, Bev has got VEGF related side effects that are most of the time difficult to manage when we combine with atezolizumab. The benefit of using dual IO, whether it is a Durva plus Treme or Nivo plus EP, is that we are giving trimming for only single dose, and when we are combining EP along with Nivo, when then we are giving it for 4 dose EP only, and after that we have to continue with the single agent immune checkpoint inhibitor. That will definitely help the finances when we consider the finances of the patient. So basically all three are having a good response and good outcome in especially the child PUG A patients. So we need to find out which patient will be doing better with which group of immune checkpoint inhibitors, depending on the toxicity profile.
Yeah, absolutely. Second thing, this study used 1 milligram of Evo and 3 milligrams of EP. So what are your thoughts on that, Dr. Abhishek?
So what we have seen that giving EP at 3 milligram is slightly toxic, having a higher toxicity as compared to what we follow is 1 milligram per kg body weight. And Nivo, we are comfortable at giving 3 milligram per kg body weight or the standard or the stat dose of 240 or 480 dose, that is 2 weekly or 4 weekly. So toxicity will be a concern when we are giving 3 milligram per kg body weight. But if you see the toxicity profile of this combination in this trial, CheckMate 9DW, it was well managed It was not
Mm.
very much difficult to manage when we talk about the Nivo AP combination arm. So in the real world practice, we need to see how it goes, because what our experience is that giving EP at 3 milligram per kg body weight had got a higher toxicity rate as compared to what we see in the trials.
Yeah, agree. Absolutely. So that's why the clinical trial scenario and the real world scenario differs. And the real world, we need to know our patients, our infrastructure, and then we need to titrate or adjust according to our patients. Thank you, Dr. Abhishek, for
Thank you, sir.
presenting your. So next we have Dr. Vikas Talreja. He's well known to all of us. So Dr. Talreja will be talking on phase 3 keynote 937 study. Thank you, Dr. Talreja, for joining us, and over to you.
Thank you, Dr. Sumit, for the honors, and I really appreciate the extra efforts that you are making at the end of the day, apart from the clinical work we do, in terms of the academic enrichment that we see, and by probably in such platforms we also learn a lot. Specifically, when we I was looking at this data, it was definitely an encouraging for us also to look at how the science is evolving. So we'll look at the latest ASCO GI study of the adjuvant pembrolizumab for the hepatocellular carcinoma for those who have got the complete radiological response after the surgical resection or a local ablation, the phase 3 keynote 937 study. Next slide, please. So the study design was important that the recurrence-free survival did not meet the criteria for statistical significant within hazard ratio crossing unity. The overall survival was not tested for the significance at the final analysis, and the recurrence-free survival endpoint was not statistically significant. There was, however, an unmet need for an adjuvant therapies post-surgical resections or local ablations as we commonly see it. Next slide. So the study comes from a background of the saying that after the curative resections of the hepatocellular carcinomas, most of them do tend to recur, and the 5-year survival rates have been dismal. In spite of telling them that we are cured of the disease, it is important that we need to look at the recurrences, and that's where the role of safety and the efficacy of pembrolizumab was being studied. Next slide. So it was a interim analysis as well as the recurrence-free survival analysis. So all those patients who have got a complete surgical removal or a local ablation of HCC were put on pembrolizumab every 3 weekly as compared to the standard, which is right now the placebo. And they were stratified whether it was a surgery or an ablation, whether the risk of recurrence was intermediate or high or very high, and what was the AFP levels at diagnosis before resection or ablation. Was it less than 200 or more than 200? And it was primary endpoint was the recurrence-free survival by the independent committee review, and the secondary endpoint was the DMS, distance disease-free survival by the independent committee review. Next slide, please. So all patients were hypothesized to have a reduced risk of recurrence, and an initial alpha was assigned to put to 0.025, and full alpha was to be allocated after the RFS was to be positive, and interim analysis was triggered when approximately 400 plus recurrence-free events were observed. Next slide. So around 4,000 patients were randomly assigned, and 476 were to the pembrolizumab arm, and 483 were to the placebo arm. And eventually, 282 completed the treatment in pembrolizumab, and 337 completed in the placebo. And the median for overall follow-up was around 50 months, with range from 30 to 70 months. Next slide. Baseline characteristics were exactly matched between the pembrolizumab in terms of the geographical distributions, the performance status, the etiology. Nearly 80% were viral etiologies, and AFP was less than 200 in around 70% of them, and more than 200 in around 20% of them. The child book scores and the prior therapies, which was nearly 80% was surgical resections, and the recurrence group was in terms of high or very high in terms of 74 in either of them, and very high in terms of 10% in either of these groups. Next slide. So a very carefully designed study, those who have a high risk of recurrence, those who have a high AFP at baseline, those who have a microvascular invasion, those who are actually a high risk group were randomly assigned in either of these groups. However, to the dismay, the recurrence-free survival was exactly similar both across. So even with the microscope, I cannot see the difference in the graphs usually we see with the adjuvant immunotherapies, but unfortunately, pembrolizumab didn't make to this event with recurrence-free survival exactly hitting unity, and not much between the difference, 46.7 versus 45.5. Next slide. If we look closely between all the subgroups, probably no subgroup had a significant benefit out of it, even if it was a very high risk resection rate, a risk of recurrence very high, prior therapy, whatever was the etiology, no subgroup I could look could have a good meaningful benefit. Uh, Next slide, please. And in terms of overall survival, as you can see in the pembrolizumab arm, you could see that the overall survival has not been achieved, and similarly was in the placebo arm, because these were curative patients at the end of the day. However, if you look at the overall survival rate for the pembrolizumab, is lower in terms of 4-year survival rate. So 81% with the placebo and 79% with the uh, pembrolizumab. So probably the curves disturbing for some time period following this. Next slide. Similarly was the DMFS, exactly similar, curves hitting exactly unity, 0.98, with not being achieved for the distance metastasis recurrence-free survival. Next slide. So with addition of some therapy, there are going to some form of events, but not leading to deaths. So that was somewhat satisfactory. But yes, nearly 90% did have some form of adverse events, with the immunotherapy causing deaths wasn't there. However, there were some grade 3, grade 4 events in 14% of the population. Next slide. Next slide. So even though we were looking for this study, unfortunately the study didn't meet our expectations. Adjuvant pembrolizumab should not be offered for all patients who have undergone a complete surgical resection or a local ablation, even though our intuition says that it might be a high risk, the patient might have a bad biological subgroup, AFP very high at the baseline, or possibly microvascular invasions. So this study has put the stamp on the paper that for us, immunotherapy is a strict no after a complete surgical resection or ablations. Over to Dr. Sumit, and would love to answer any questions if there are any.
Thank you, Dr. Vikas, for that lucid presentation. And very rightly, the HCC, we always fear once we take it out, it will recur. But unfortunately, the options that we have as of today are very limited. And we have nothing in particular in adjuvant setting. We have a study, I am Brave 050 in the adjuvant study, which is for the atezolizumab in adjuvant setting for the high-risk patients, which is showing some trend towards improvement. And again, we do not know which subset of our patients will benefit. And adjuvant, we have STORM study. Again, we don't know how to use, what to use as of now. And probably what we don't have as of today is IO plus TKI study. That is lacking. So what is your take, Dr. Vikas? What do you think? Because is it the tumor microenvironment or it is the variant histology which leads to HCC? So why the adjuvant setting it is not working? No strategy is working.
So I believe HCC has been a disease where we haven't made much advances as compared to the lung and the breast, and it's probably the microenvironment that's the end of the day which takes a call. If we look at the overall survival, if we don't give for some population anything, and I believe they did a very beautiful study in terms of comparing it with placebo. They didn't compare,
Mm,
so suppose pembrolizumab with pembrolizumab plus
mm,
some form of TKIs.
mm,
I think probably we need to identify through some genomic profile that what are those 40% of population that fail, and what is probably that some form of mutation that occurs in them, and then hit that mutation. It would be a probably a better study. But for now, 60 to 70%, those who do well, they do well irrespective of whatever you do. And those who don't do well, immunotherapy so far is not the answer. We need to look for alternatives.
mm. Absolutely agree. Okay, thank you, Dr. Vikas, for your insights on HCC in adjuvant setting. We hope to see a recent in near future new updates and how to go about it in our clinical practice. So be there. Thank you very much. So Dr. Shefali Sardana, dynamic medical oncologist from Delhi. We love to hear her. Yesterday we discussed about metastatic pancreatic ductal adenocarcinoma. It was about
Yeah.
KRAS G12D. So
Yes.
another interesting study which she's going to present, it is about elraglusib plus gemcitabine combination. So over to
Sure.
you, Dr. Shefali.
Thank you, Dr. Sumit. Dynamic तो पता नहीं, but
Yes,
medical
very
oncologist
dynamic.
तो okay. I'll try to come up to your expectations, I feel.
Yes.
Okay. Yeah. So can somebody share the slides?
Yes, ma'am.
Sure. So very good evening, everyone. And I think this is very important topic because neither immunotherapy has made much of difference ever in treatment of this deadly disease. Neither any newer molecule is a miraculous thing. So this is an unmet need to have something for metastatic pancreatic ductal adenocarcinoma. KRAS we know is a signature mark for here, and if we are successful getting something targeted in that form, I think that may be a little help. However, this study is a randomized phase 2 study. This was done in two parts, 3A and 3B, of elraglusib plus gemcitabine nab-paclitaxel versus gem-nab-paclitaxel previously untreated metastatic pancreatic ductal adenocarcinoma. So I'll give you a little brief about the part 3A, which is basically the dose decision part of elraglusib was there, and where elraglusib was used as a 15 milligram per kg twice a week type of regimen. And once this part 3B was planned and the dose was reduced to 9.3, and that is once weekly for elraglusib. So probably the neutropenia was the concern, and the toxicity profile drove that decision that it could be once a week and with a reduced dose rather than a higher dose or twice a week regimen. Next slide, please. So basically, something about the previous trials, if you can see that various trials evaluating FOLFIRINOX, gemcitabine, nab-paclitaxel, NALIRIFOX, every trial has shown that median OS is somewhere near about a year or so. And in the real world practice, we always counsel the patient, okay, it could be 9 months, maybe in the best of scenarios, you could cross the year. So, however, none of the trials has shown a magic response in this disease. Next slide. So what is elraglusib basically? Nowadays, we all know that much of the work is being done in the molecule where they target the metabolism, basically the microenvironment rather than a mutation. And that is how the GSK3B molecule, that is elraglusib, is there. And basically, it's a facilitator of the cell signaling pathway. And it is involved in glucose metabolism, which ultimately works through the insulin signaling and WNT beta catenin activity. And this has a crosstalk relation with the RAS, NFKB, and epithelial to mesenchymal transition pathways and immune activation pathways. And that is how this works basically to increase the chemotherapy cytotoxicity as well as the immune modulation, so that the immune cell infiltrate the tumor microenvironment, and that is how they help in the chemotherapy induced cytotoxic effect and better kill the tumor cells. Next slide. So this study randomized into 2:1 fashion into the experimental arm versus the standard of care. The experimental arm included elraglusib 9.3 milligram per kg weekly, along with the gem nab-paclitaxel in a standard fashion of day 1, 8, 15 every 28 days versus the control arm of gem nab-paclitaxel. And the primary endpoint studied was 1 year overall survival and median overall survival, while secondary endpoints were overall response rate, duration of response, PFS, and time to treatment failure. Next slide. So this is how the consort flow diagram is. And if we can see that basically the people who were randomized between the GNP alone versus the ELRA arm, so there were kind of side effects, few people withdraw the consent, the toxicity consent from concerns from the part 3A, where ELRA was used twice a week type of regimen, they decrease it to once a week. That is how this study was carried out. And based on the assumption for 1 year overall survival rate of 55%, they thought that the sample size of 207 patients would be 80% powered to answer that question of primary endpoint and the secondary endpoints. Next slide, please. So if you see the baseline demographics, I think in terms of the gender and all things, they were well matched. Basically, the majority of population was white. However, there was some representation from the Asian or the non-white population and different ethnicities. And as far as the disease status is concerned, almost 70% were metastatic at the initial diagnosis versus 99%. A few percent were included till the time of randomization also. Next slide, please. So if we see that this study could meet the primary endpoint of improved survival, if you see the hazard ratio is 0.62 and the median overall survival in the experimental arm was 10.1 months as compared to 7.2. However, if we see the numerical values in both of the arms, you can see that gem-nab-paclitaxel generally in this trial showed a little lesser kind of response. In other trials, gem-nab-paclitaxel reported 11 months of median OS. However, in this study, it was 7.2 months for gem-nab-paclitaxel versus 10.1 for the experimental arm. That may, I mean, reason precisely because the full trial is not available, so I don't know. But basically, the earlier deaths or earlier toxicities may be one of the concerns. Next slide. So they made sure that the patients who are included for intention to treat analysis could receive at least one cycle. And the median OS, as we discussed, in the intention to treat population in the experimental arm was 12.5 months as compared to 8.5 in Gemnap-Peckley. And 12 months overall survival was 52% versus 28%. So that was the good part of this study, on the basis of which they concluded that, okay, it was a significant difference in the 12 months OS and the median overall was statistically significant. Next slide. So if you see the forest plot curve, I think all of the subgroups, be it the liver mets at baseline or the ethnicity or the CA 19.9 values, they all fairly did well in the experimental arm as compared to the conventional arm. Next slide. In terms of progression-free survival, again, the median progression-free survival was 5.6 months in the experimental arm versus 5.1 month in the Gemnap-Paclitaxel arm. However, the hazard ratio was 0.83 and it was, the p-value was not statistically significant here. The complete responders, however, was one patient who was who had a complete response, and partial response was 27 versus 21%, and the stable disease was 32 versus 34%. So the disease control rate basically was 40% in the experimental arm as compared to 33% in the Gem-Nab-Paclitaxel arm. Next slide. Safety profile, I think there were two main concerns. One is the visual impairment and fatigue, and second is the neutropenia. And the grade 3 event was, in terms of the fatigue, was 25% actually, as compared to 16% as compared to 5% in the experimental versus the conventional arm. And neutropenia grade 3 was actually 53% in the elraglusib arm versus 32% in Gemnap-Pecli arm. Next slide. So they could prove that basically how GSK3B molecule work is it basically tends to alter the tumor microenvironment, and hence there is more infiltration of the CD8 T lymphocytes, and the cold pancreatic tumor actually behaves like a hot tumor, and that is how the cytotoxicity effect of chemotherapy enhances, and the major effect is there. So that is how they could alter the pre and post dose they could draw the pre and post dose tumor samples and could show the immunophenotyping in terms of the altered tumor microenvironment. Next slide. So to conclude, in terms of the statistics, the experimental arm significantly improved survival over the conventional Gem-Nab-Pecli alone in the intention to treat population. The median OS was 10.1 versus 7.2 months, and the 12-month OS was actually double, 44% versus 22%. There was 38% reduction in the risk of death, and the correlative studies of immunomodulatory changes and some co-mutations, they could predict the poor outcome, and the median PFS was similar between the two arms. Now, the survival benefit was basically driven by the alteration in the tumor microenvironment or immune modulation that is yet to be seen. So I conclude my study here. Any questions? If I am able to answer, I'll do that. Thank you.
Dr. Shefali, thank you very much for being here. So definitely we want to hear more from you. So
That-
your presentation, very good. Thank you very much. Your understanding of the disease. We know it is a deadly disease. We don't have
Yeah,
anything much to like manipulate. But
yeah,
three things from your slides. One, the side effect neutropenia, but you mentioned the visual impairment was there, though temporary. It was quite high, 68.4% you mentioned.
yeah,
Second thing, if that is there, the patients usually get worried something to do with the eyes. Though
yeah.
reversible, then obviously they will be apprehensive. So any biomarker to choose at this point of time, I think it is not there, but that would help in choosing our patients, right?
Yeah, yeah. Sir, in terms of biomarker, so I don't think these molecules have yet to avail a biomarker to choose
Well,
and pick. But however, we know that pancreatic and hepatobiliary basically they have a lot of things going on in the tumor microenvironment in terms of the pathways which are involved, specifically the beta catenin and WNT pathways. So they basically work through the glycolysis or other pathways to merge into that. That is why insulin regulation is there. So I think there is a lot of scope, because nowadays, even if you see the hepatobiliary and there's pancreatic for that matter, the molecules which are little showing a response are these kind of molecules only, which actually affect the metabolism rather than the mutational part, because these are considered as the cold tumors. But as of date, I'm not aware of any biomarker-based selection of these molecules which is going on.
yeah, absolutely. It is not there as of now. It is not there. Speculation is there. And another interesting thing that you said. So we know that we know that we cannot manipulate these tumors, these kinds of cancers with medicine, like the conventional medicines that we
Right,
have,
sir.
chemotherapy. And also we are looking at the metabolic pathways, like this is glycogen synthesis kinase pathway. It is affecting there.
Yeah,
So, so as you said, ki we are making this hot from the cold tumor to the hot. So do you
yeah.
see, like in the future, maybe just a hypothesis, whether can a combination of IO with this drug in future may help us?
Absolutely, sir. So the basic purpose is if you have a immune infiltration type
Yeah,
of
CD8, you said
microenvironment,
ki there was
yes.
multifold
And
environment
yes,
was
and
there.
if the chemotherapy is producing a enhanced cytotoxic effects,
Hmm.
I mean, this is a hypothesis, but
Means,
I
yeah,
presume
exactly.
that the more antigen or new antigen exposure
Mhm.
and the tumor microenvironment alteration, IO may have a role in
Yeah,
addition to
in
these
com
molecules.
yeah,
Absolutely.
exactly. Exactly, because it is making the tumors hot, which we cannot combine in the conventional way. So maybe there is a hypothesis, probably it may help us in.
Yeah, sure, sir. Yeah.
Thank you very much, Dr. Shefali. So
Thank you, sir.
now I think Dr. Jatin Sarin is there. So he is the big boss. He is going to decipher the data, and he will bring out the finer points and nuances out of this. So Dr. Jatin is a very good friend and a very senior consultant and a senior to me. So over to you, Dr. Jatin, for the panel discussion.
Thank you, Sumit. You are a friend, and don't call me senior and all. You're a great colleague, and
Thank you,
uh,
Dr. Jatin.
always a pleasure talking to you and discussing you. And in fact, the nuances you asked me to discuss, you have asked the most pertinent question to the individual abstract presenter. So I think my job is just to reiterate the things that it's more of a food for thought because they are all difficult to treat cancers, upper GI
Yes.
malignancies, and a lot is happening research wise, and the newer kinds of molecules they are coming up, and the way to judiciously use them. So, and the data which has been presented, I think we need to thrash out that data. Basically, how much of it is practically feasible for the Indian patients.
Yes.
So, who all are the panelists? Can
So
someone invite the panelists?
I think Dr. Venkat Babu is there.
Uh,
Venkat Babu is
I'm here.
again, he reads in depth, academician. Dr.
Yeah,
Devesh is not well, so he is not joined. Dr. Vikas is there, Dr. Shefali is there, and
yeah,
Dr. Nikhil is there. So the whole idea is, as you rightly said, we have enormous data. And
yeah,
as we discuss, dissect, and try to understand how we can incorporate into our practice, it is meaningless. So
right.
that's why, even if they are small points, they are important points to
Yeah.
discuss. So over to you, Dr. Jatin.
So we discussed four abstracts, and out of that, one was a negative study, and the three showed some positive results. So let's start one by one. Let's come to the Matterhorn first. Let's start from stomach. Yeah. So Durvalumab to float, yeah, everybody was actually trying to add on IOs in the neoadjuvant and adjuvant setting in stomach cancer because in metastatic setting they really helped. Is there any to anyone can take this question? First of all, for how many years in your practice you have been using FLOT? For how many years of your practice you have been using individually? Yeah, start from anyone. Dr. Venkat?
Yes, sir. Good evening. So for the last since the time I was working in RGCI, I'm using so it's done 6 years. I'm
Oh,
using it, sir.
6 years you're
Yes, sir.
using FLOT. Right. Yeah. Yeah, I can see Dr. Shivali.
Yeah,
Oh,
similar, sir. 4 to 6 years.
yes, Dr.
I've been
Vikas.
using, yes.
Dr. Vikas. Dr. Vikas.
Sorry, I was on mute. Yeah, since the incorporation time immemorial, I have been using FLOT because it has become so in resectable cancers. I believe the best therapy so far is FLOT
Hmm.
in terms of not
Hmm.
only you get a good pathological complete response, but you also get the best of all worlds. So the combination of taxanes with already which we were using was for Fox
Mm-hmm.
was
Mm-hmm.
a great advantage to it.
Mm-hmm. Right. So the usage of lot, thankfully, it's in the non-metastatic setting only.
Yes, sir.
So
Yes.
Mostly.
metastatic, we have a docs kind of protocol. We have some studies available to suggest the similar protocols. Actually, they have evolved from metastatic setting only, for that matter.
Mm.
So I do believe that docs kind of protocol is there for the metastatic setting also. Some phase two
So,
studies,
so
yes.
Dr. Shivali, what percentage of your patients on FLOT were able to take all the doses of FLOT pre-op,
Yeah,
post-op? What percent
yeah.
in your
Of
practice
course,
routinely?
of course. So I would divide this question into two parts. If it is a young gentleman, of course, almost 60 to 70% would tend to complete that. But if he is elderly, the number goes to say hardly 40%. Then I have to do sometimes the modification that I give 5 FU over 46 rather than the 24 hours if I tend to use a triplet in this
Okay.
setting. So that is what I'm trying to do. Again, in
Because,
spite of doing those modifications, it's not that 70-80% of completion rate, I would agree.
okay, rest of the people, what is the discontinuation rate, or maybe what percentage of patients are able to complete FLOT?
The pre-op, mostly 90% of patients they are able to complete the planned cycles because float we usually select those patients who are quite fit and no comorbidities. And
Mm-hmm.
if, but post-op, it nearly 30 to 40% of patients they have difficulties in completing the rest of the 4 cycles.
Mm-hmm. Dr. Vikas?
So, if we go by probably the trials which were originally designed, so in Matterhorn it was around 10% of the patients who didn't completed it. In real world studies, around 30 to 40% of our patients don't get to complete the post-operative float. So 60% is to what is overall completion rate. But I believe various factors do play a important role. Uh,
Mm-hmm.
for me, I think 50% would be in terms of the completion rate post-op for patients.
Okay. So, with the addition of durvalumab or IO to FLOT, would this percentage be anyhow affected? Or, I mean, it's a well-tolerated drug, and the number of patients who were able to complete their full cycles would remain the same, and the addition will just add to the benefit, and there won't be much of a discontinuation due to side effects.
Uh,
Anyone?
uh, I don't think that durvalumab per se leads to more discontinuation rate, but of course, the side effect which I have seen gets potentiated is fatigue. So people do have a lot of fatigue, weakness, tiredness. Uh, these kind of side effects do trouble them, but
What, what,
discontinuation rate,
what
yeah.
about diarrhea? What about diarrhea?
Diarrhea so far with the durvalumab addition, I have not come across for the reason of discontinuation, of course.
And who's the fourth panelist? I didn't see the fourth panelist.
Dr. Nikhil is there.
Dr. Nikhil. Dr. Nikhil,
Yeah, good evening, sir.
good evening. Yeah. So, Dr. Nikhil, what was the commonest reason of not completing full flood cycles in your patients? What was the
So,
reason for the discontinuation, or what was the reason for you to stop the treatment in conventional flood? And then we'll talk about addition of durvalumab.
So, sir, in conventional flot, mostly what we see is myelosuppression and GI-related side effects like nausea, vomiting, and diarrhea. And fatigue, as mentioned, we see post flot a lot. So, I think these are the main reasons: the GI side effect, the myelosuppression, as well as the fatigue, which is encountered with the flot regime.
Okay. So, looking at this data, can someone move the slides to the results of? We all know this trial. Let's move to the results. Yeah, yeah. Stop at this. Stop at that. Yeah. So, given the data here, in which most of the subsets benefited with the addition of durvalumab, as far as the EFS is concerned, given a choice tomorrow, and if your patient can take it, would you add on durvalumab to the FLOT regime?
Of course, given a choice, I think the eligibility first, of course, is say tap more than 1%. It's not for the biomarker absolutely negative.
Okay.
So given a choice, I would add that because in my practice, I don't know whether others would agree or not. There is a discordance in the radiopathological response when we give FLOT. We have seen couple of or so many now, and we were planning to report it also that if you see a radiological kind of say very good partial response or a near complete response, but when you operate upon those patients there is a heavy nodal burden which is the residue. So this kind of discordance we have commonly seen, and if some drug is giving you some more advantage in those terms and the DFS benefit, I think I would be tempted to use that.
Okay. So, okay. So, in this particular regime, with the addition to Valumab, there was an increase in PCR, there was an increase in MPR.
Yeah.
But do you think that is actually responsible or translates into EFS benefit?
So translate, so the maturity data I think may make us more wiser, but the kind of EFS nowadays we are using as a not as a absolute surrogate, but as a good biomarker in terms of the response assessment in the operative or the radical settings. So I
Okay.
think that makes sense to if we have a PCR or a EFS to have that advantage with the newer edition of
Because
the drug.
because in this particular
Yeah.
trial, please move the slides further.
So, if
Uh,
I may say,
yeah, yeah. Please, Dr. Vikas.
so, 3 points that I would like to highlight specifically for this trial was, as
Okay.
Dr. Shifali said, that we all feel that the patients, specifically the resectable gastric cancers, they do get a good clinical and radiological response with FLOT, but they never get a good pathological complete response with FLOT, and that's where this addition of durvalumab, which increases the chances of the pathological complete response to nearly 3 times as what we are achieving. The second has been the bone of contention with medical oncologists is whether it is adding life to the patients, and that does make into translate into overall survival by giving in the flot arm only it was 45 months, but with the durvalumab addition, the median overall survival has not been reached, and that means it is curing this disease. And if we have to go from the economic point of view, if you look at the numbers needed to treat for the extra pathological complete response or an extra death prevention, it is in terms of less than 10 patients. So 5 to 6 patients for an extra pathological complete response and a 7 to 8 patient extra for preventing one death to the patient. That makes it a very cost effective population. And if we look also in between the lines, even if we give the new adjuvant durvalumab and if the patient has got a pathological complete response, we can skip away in giving an adjuvant durvalumab if the cost effectiveness doesn't work out to be, because you have done what needs to be done at that point of time. The patient has achieved a complete response, forget adjuvant durvalumab, and probably get the best of all worlds around.
So you feel that adjuvant durvalumab, because the data, final data shows that whether you get a PCR or no PCR, that doesn't translate into the EFS benefit actually in this particular trial. So you feel that you can forego the adjuvant durvalumab if you tend to get a major pathological or a pathological complete response.
Absolutely.
That one you want to say, Dr. Vikas?
Yes, sir. Sir, it
Yeah,
is
good food for
possibly,
thought.
I
Yeah.
not advised, but yes, I can safely say that those who have achieved a pathological complete response tends to do well, and they are those who are long-term survivors. So probably that gives you a good biology selection as well as those patients an edge over the chemotherapy.
Okay, so
And it is irrespective of whatever the PDL1 is so far now. So probably the recommendation is in terms of more than PDL1 positive population, but the CPS score being either the pathological complete response has improved, and if you look at the delta of that, probably in those where the CPS was less than 1, the float also didn't perform well. So float was 5%, and with durvalumab addition, it was 16%. So if you look at the delta, it was more in terms of 11% in terms of those who had a CPS less than 1.
so
But nonetheless, it is
So again,
important.
this is more of an hypothesis generating. As yet, we don't have a data if we can forego development, because as for now, we have a trial in which you have to give at least 10 doses of adjuvant durvalumab. And maybe I feel that might add to, yes, IO does add to the efficacy. There's no denying fact in that. So given a choice, if patient is affording and specifically in PDL1 positive, we all will be tempted if someone has Sumit, you want to say something about it?
No, sir, I don't want to. Yes, definitely, if given a choice, would like to add. But
You like to add?
yes.
Okay.
But only
So,
setting is if MMR deficient, probably. Then again, whether to go with chemo, that data is not there.
okay. So that's a different discussion altogether. Yes, in this kind of malignancy of stomach cancer, and especially with heavy nodal burden, strangely, durvalumab has worked well in neoadjuvant adjuvant setting in node positive gastric cancer as against what we have data in bladder cancer. So there are strange things or strange data. I don't know. So let's go to next abstract. I think we are running out of time. So this particular trial. So who all have used Nivo EP in HCC? Let me first ask this. Who all have used Nivo EP in HCC?
So I haven't used it.
Anybody has used Nivo EP in HCC?
Not yet.
Vikas?
I have used in a second line situation. So
Hmm.
patient was responding well to nivolumab and then progressed and then added IPI and had a good response.
So what
So
dose of EP you used?
I use 4 doses of 50 milligram and that's it. The
Yeah.
patient got a serological response, a radiological response, and just because of the fear of the side effects, I stopped. I didn't put on maintenance, and so far the patient is doing well with only 4 doses of AP.
So my
Additional.
intent of asking you this question is that who have used in their life ipilimumab 3 mg per kg? Has anybody used?
Only in
Every,
one patient of mucosal melanoma. And I didn't dare to use it anywhere else.
yeah.
So that's why this meeting is there to learn from each other. If someone has used, it will
Yeah,
embolden
I
us.
mean,
I
yeah.
will be tempted to use. So
See,
far, we have used
see,
only
we
1 milligram.
are all here to discuss the things, practical aspects of,
Yes.
and then looking at these trials, because we all have burnt our fingers.
Right.
going by the guidelines and all. And our patients are really suffered, and these are all expensive treatments. And for me, I would say I would never use ipilimumab 3 mg per kg. But okay, let's see this data in the context of other IO data in HCC. Atezolizumab and Stride, this Himalaya. So, what do you think about it? I mean, if we actually see all these three studies, what are the things pro in favor of this particular study which tempt you to use this combo versus what are against to use this combo? Anybody?
So,
Vikas? Yeah.
yeah. Okay. Dr. Vikas, you can go ahead and
Okay, perfect, sir. So, definitely a good option. For major subgroups, I would say, if I have to take it, as said, 40% discontinuation rates in terms of addition of that EP is there. But Asian population having a similar efficacy, the key effect was that previous it was thought that viral histologies don't perform better, but if there's a viral etiology, Nivo plus AP does have a good data for it. If we look at the 18-month PFS. So we don't look at the PFS in terms of what the absolute figure is, but if you look at the 18-month PFS rates, it is nearly double. So 18% with lenvatinib as compared to 36% with Nivo EP shows that there is a delayed response for it, and that is the durable response. And that's where those who tend to get response, the response are going to be till 30 months. If you are planning some form of definitive therapy, the complete response rates are nearly 4 times. So with lenvatinib, you have a 2% complete response rate. With Nivo plus EP, you get 8% complete response rate. So probably at that time would be a benefit of adding some form of local uh, therapy. Also, if we look at those population who have a high baseline AFP levels, those who have probably child book B score, they also have a significant subgroup benefit out of that, where the overall survival has shown some form of benefit. So
Child
it
book
is
B.
subset. Child
So,
book B.
can we move the slides to the results of this trial? Yeah, fine. So, my next question is, who all have used IO combos in Childbook B?
So B7, I have used Durvatremi. So Durvatremi, I have a couple of good experiences. However, the stringent selection criteria makes it a challenge. So majority we have, I mean, VP4 type of patients or B8, B9 type of, I mean, these kind of patients which become a real challenge. But of course, it's difficult to find absolutely Child-Pugh A or B6 or B7 kind of patients in whom we can try this. These kind of things are there. However, one thing which I would pro for Atezo-Bev is that it is very easier to use. Even there is some data available to say if you have a main portal vein thrombus also. I mean, this is the drug combination which has some data that it will work. Otherwise, Durva-Tremi trial has excluded exclusively this VP4 kind of patients. And in terms of the viral thing, if it is well controlled, I have couple of patients who were HCV positive, well controlled, and they did well on Durva-Tremi as compared to Atezolizumab. But it's not a head-to-head comparison. I have both kind of patients. This my impression over the say anecdote experience or whatever I have.
But what was the comparator arm in Atezolizumab, Dr. Shivali?
I think it was the sorafenib per se.
Yeah.
Yeah.
Lenvatinib was not.
No, it was not there, sir. Yeah.
But if you compare it with lenvatinib, anybody is aware atezolizumab being compared with lenvatinib? Anybody is aware?
Uh, I
In
don't
the
think there's a trial.
So real world may be there data, but the trial-based setting though was sorafenib.
in the adjuvant
So
setting,
that is
yes.
a positive aspect in this particular trial, that lenvatinib was also part of a comparator arm.
Uh, could say, but of course, so the better tolerance and a little better response as compared to sorafenib, that trial too we have.
Because the
But
kind of sorafenib
yeah,
dosages used in the trial we never use.
absolutely, sir. Agreed.
But lenvatinib, definitely you use 8 mg, 12 mg doses. It's a better
Yes.
tolerated drug.
Yeah.
So, anyways, just for the sake of information, atezolizumab was also compared with lenvatinib in real world, and also there was a meta-analysis in which both these specifically with the as against the lenvatinib, atezolizumab was done, and real world didn't show any benefit, be it OS, be it PFS, not much of a benefit in either of the thing. And in non-viral etiologies, rather lenvatinib fared far better as compared to the atezolizumab. And in viral, yes, definitely they have a benefit in this thing. So, but still, I mean, it's a learning for most of us. And but given a choice, as you said, you are very comfortable with atezolizumab. And yes, I think the hands-on experience we all have is with atezolizumab. So, Dr. Venkat,
Yes, sir.
what has been the IO combo, commonest IO combo you have used in HCC? Atezolizumab, Durva, Tremi. Since Nivo EP, I think not many of us have used.
Yes, sir. I have used Bev in two patients, sir. Rest of the patients, I have mostly used recently the tislelizumab, sir, plus Lenva. So that
Just
is
Lenva.
the May, yes, sir, plus Lenva. There is a data that is recently published which has showed the better response rates. The reason I have used this combination, sir, because I work in a setup where I do not have a population who can afford Atijo plus Bev mostly because it becomes too expensive for the patients. And to convince them that with such a response rates in such a disease with a shorter lifespan to use such a costly therapy would be difficult in a rural area. So that's the challenge.
Okay, so you have used Tisle Lenva. So
Yes.
you have used two drugs which are used as single agent in first line as a combo.
Yes, sir, because Tisle per se has the response rates are not so great. So there is a
Yeah,
data published from I think Chinese population. Tisle plus
fine.
Lenva has shown
Yeah,
better PFS.
fine. Anyways, so who has not commented? Dr. Nikhil.
Sir, I have used A plus B quite often, and specifically for patients who have VP4 disease, I think it works very well. STRIDE is a regimen where the responses are very slow, so where we want rapid responses, I think A plus B is a better regimen. And STRIDE I have used in couple of patients, and it has worked well in non-viral as well. And recently with this date trial, the Checkmate 90W, I think it is very exciting because the median OS, which is shown with this study of around 23.7 months, I think that is the highest. And the
Have you
objective
seen the
response,
median OS of the comparator arm?
sir, the Nivo AP arm, sir.
This kind of median OS in the comparator arm, lenvatinib or sorafenib, 20
Yeah.
months median OS. Have you ever seen?
No, no, sir. But sir, the objective response rate 36% and the durability of response of around 30 months. I think I've recently started giving the option of Nivo-IP as well to the patient. Although I have not used it so far,
Okay.
but
When you give
yeah.
the option, the what dose of ipilimumab do you suggest?
So, sir, AP I've used in one patient in melanoma 3 mg per kg, and the patient did not had any immune related adverse event. So far, the experience is limited. But I think we will all learn by giving such doses. I
Sure.
have not given 3 mg per kg in my practice
Fine, fine.
for HCC.
So at least someone is giving that 3 mg per kg of ipilimumab comfortably. So that's fine, and that's good to hear. Any other comments from anyone?
Yesterday, in the discussion on HCC, we
Uh,
had Dr. Chandra Gowda. He spoke on HCC. So
okay.
if we share his experience, he has put 3 or 4 patients on 3 milligram EP.
Hmm.
So he said he is comfortable giving it and not seen any such side effect till now. Either he is lucky or maybe we will learn from each other and we will also like try to give it in the other patients.
Yeah,
And as per NCC and TISLI, I think is there in first line as monotherapy.
monotherapy. Yeah, it's in monotherapy. So,
Yes, sir. The NCCN says it's a monotherapy,
Yeah.
but because the data I have combined, I take a special consent before doing that.
Yes,
so the thing
absolutely.
is, there are few practitioners who are saying that they're comfortable using EP 3 mg per kg. That's a learning, and will as more and more experience is gathered, then and if this combo
Mm.
can be used safely, then nothing like it, because nowadays we are having generic Nivo also.
Yes.
So it will be a good thing for the patient. But the only constraints we feel is of the tolerability of ipilimumab. Let's go to the next abstract, and we'll be really fast about it.
Jatin, possibly the
And
next act is mine. So that is a negative study. Probably we can skip, but I will give one penny of thought for this
yeah, sure, sure.
combination.
I think that will be of real great help. Yeah.
So I agree with all of the panelists that since ATZ Bev was first to enter into this game and we all are comfortable with the ATZ Bev combination, so far no complaints. But what happens after ATZ Bev? And that has been always the bone of contention, as it's not going to cure the disease, but there is going to be somewhere progression. And that's where the Nivo plus IP data does come. So it was definitely the first line study, but if we look at, there has been a number of multicentric international studies where Nivo plus EP was given post ATZ plus BEV combination. And if we look in between the lines of that also, to you see that nearly 50% of them, so 42% have some form of response rate after ATZ BEV. That shows it is having a meaningful clinical activity. And that response has been responding for nearly 20 months. So those who got a response post ATZ plus BEV and you used Nivo plus AP, 20 months, that duration of response is going to be there. And who are those who are going to get benefit out of ATZ plus BEV and are going to give to Nivo plus AP are those who are getting some form of thyroid dysfunction. So anybody who experienced immune related adverse event while you are giving ATZ plus BEV, and then you give they progressed and then you give Nivo plus EP, they are going to those who get respond. So because all those who responded post ATZ BEV, the 11 responders in the Nivo EP, all of them had thyroid dysfunctions at the baseline. So that's probably my takeaway for it.
Vikas, yeah, that's an important takeaway that yes, you can reserve this combo for the future, because yes, post Atizobev, you have either Cabo or other few TKIs to use. The only thing is, if suppose you get an immune related hepatitis on these drugs. Suppose you get immune related hepatitis and liver dysfunction on. So what happens then? I mean, is it easily manageable? Uh, Especially in the setting of HCC, when
So,
you have a very labile, you're dealing with a very labile liver function. Your liver, you have a liver disease, and in due course of time, the drugs you use in first line also tends to have some impact on liver function, especially when the disease progresses.
so any,
So, yeah.
anything related to hepatotoxicity is lethal.
Yeah.
So that's the probably the carry home
Though
message.
this particular study showed that they had a transient hepatotoxicity, and that hepatotoxicity was manageable in future. But I think I'm a bit skeptical about that thing. I'm a bit skeptical. But your point is well taken, that yes, if someone is tolerating Nivo EP, you can give a choice. You can give a choice, and it leads to some very good results in that particular line, in such a dismal malignancy. Yeah, I totally agree on that. So the next study is next study, please. I think we skipped that study. That was a negative study. It was in BCLC-A basically, and we are not able to get. There have been adjuvant study with TKIs also. They have also failed. There was one study I think we are not able to discuss out here, that with ablation TACE followed by lenvatinib. That
Yes.
was a positive study. But this particular study. So just I want an opinion of people in general. That is the adjuvant thing in HCC totally out, or still there is yes, it is an unmet need, or do we feel that adjuvant is not going to have much of an impact in HCC? Just a food for thought. Anyone?
Uh, Dr.
Yeah.
Jatin,
Yeah,
basically it's the unmet need, definitely yes, because liver microenvironment is very bad. We cannot manipulate the tumor so easily.
yeah.
But I think there was some small study of atezolizumab in the adjuvant setting. Rest all the
Hmm.
studies have been negative. It was a small study for probably in high risk HCC, which had shown some advantage there. Apart from that, as you said, post-test Lenva data is there,
Hmm.
and post-test nothing is there. So some small studies, maybe we will keep on trying till we succeed, either
Yeah.
by hook or by crook, either by statistics or by real world experience.
Yeah.
So
So see, yes, it's an unmet need because yes, definitely we can nip the disease in the bud. So let's go to the pancreatic cancer. Dr. Shafali,
Yes, sir.
are you there?
Yes, yes, I am very well there, sir.
You're
Yes.
there. Okay. So, uh, uh, what are your personal opinion about this particular study? GemNAP
So,
is a go-to regime in poor performance status, elderly, metastatic pancreatic cancer in which you're not able to give FOLFIRINOX, or these days NALIRIFOX,
yeah.
right?
Yes, sir.
So we have a targeted agent, targeted, not exactly targeted, because this is actually tyrosine kinase, which is indirectly linked to the other biological drivers. What do you think that this particular molecule, in addition to GemNab paclitaxel, looking at its side effect profile and all, would this be a game changer in future? Laribrucib.
Yes, sir.
Uh,
So, I think difficult to answer as of now. Why? Because there are so many crosstalk pathways which are involved in these kind of molecules. It's not only the WNT beta catenin or the glycolysis pathway which is involved, but the RAS activation and other crosstalk pathways are there. Now, very difficult to say whether it will give us a OS kind of benefit in the long run. Long run, not sure. But of course, this generates a very good hypothesis, like Dr. Sumit highlighted, that if we can add IO to it, will that make a long-term difference in the treatment of these kind of patients? However, till date, not very much impressed by the kind of the data which is showed, though it was a positive study. But again, the difference is like numerically 2 months. Statistically, we may be vouching for anything, but
Mm-hmm.
I don't think that unless until we have a long-term data available, this is right now going to make any change in the practice. No.
Could the limited number of dosages be sufficient enough to cause an impact in the total regime?
So that was the need actually, because when they saw in the part 3A, actually the incidence of neutropenia was, and that to the grade 3, side
Mhm.
effects was too much. That is why they had to decrease the dose to almost from 15 to 9.3 and twice weekly to once a weekly regimen. So I think that is the dose optimization which is required, because in this setting, if the grade 3 neutropenia is to the tune of 60%, even after dose reduction, that is little significant.
So that's what I'm asking. If we give this particular drug in just one or two cycles of Gemnap
Right, sir.
would
Mm-hmm.
would it do its effect, or would it be sufficient enough to carry on? And maybe in future, as you said, that it causes some immune modulation, more
Yeah.
number of CD8 plus cells in the tumor microenvironment, which in a tumor which is traditionally and very obstinately a very immune cold tumor.
Yes, sir. So, I mean, to my limited understanding, like I discussed, that there are so many crosstalk pathways which can be activated. So, I don't think that one or two doses would be sufficient enough to control that tumor microenvironment at the go. Either we need a long-term maintenance, or we need a add-on IO or some kind of drug which can consolidate the response. That is my thought process.
Fine. So my other panelists, anybody, Dr. Vikas, Dr. Venkat, Dr. Nikhil. So what do you think about this data of Elaribrucib along with Gemnap paclitaxel? Anybody? Do we have anyone?
So,
Hello, sir. I think so. Pancreatic cancer is pancreatic cancer because of the of microenvironment.
Okay.
Despite the decades of research, nothing has been there. So, if some drug is there that will improve even few months of disease control, then definitely I would think of it, sir.
You would think of it. Vikas? Dr. Vikas is there? I don't think he's not
so
there.
So, so as Dr. Shefali said, there are so many challenges there. One is the tumor microenvironment, then pancreatic cancer, hepatopancreatobiliary cancer are altogether a different ballgame
Hmm.
because they are very hard to manipulate.
Hmm.
And we have so many resistance pathways there and crosstalks which we do not know how to manipulate. But
Hmm.
definitely this kind of a drug which works in a different way, probably as an adjunctive therapy, maybe in the coming days, more such drugs or better understanding of these drugs or manipulation of modification of these drugs may help us in some way. Like the same way in PROC, this platinum-resistant ovarian cancer, we have this new drug, relacorilant, which
Hmm.
is again in first line, may move to first line also because the results are very impressive. And regarding this study, as Dr. Shefali said, traditionally in Gemnapacli, the median is around 10 to 11 months or 12 months, but here it was just 7 months. So
Hmm.
why so we do not know this difference is there, whether
Yeah.
overall we need to look at this. And secondly, this is a just phase 2A study,
Yeah.
randomized phase 2 study. Maybe a
Yeah.
bigger study will help us.
We need a bigger study. So we are wiser with this discussion. We all are wiser, and thank you all for being part of this discussion. And yeah, we are going to have a total change in the treatment algorithm of most of these malignancies because initially the options were very limited, and though not much bigger strides have been made into the things, but yes, still the future somehow looks bright.
Yes.
And as in now we learn more about the biology of the disease. So I thank Sumit once again for inviting me to be part of this discussion and making me more wiser on this. Thank you, each and every one. Yeah, over to you, Sumit.
Yeah, thank you very much, Dr. Jatin. So basically, I got so much learning points from there and food for thought. So first was from Dr. Shefali. So I've learned if we are not able to give plot for 24 hours, you extend it. So I was not able to think this. Now I will start thinking that way also. Ki yes, this can be done by. So to slow the rate what is there. So at least you can prolong, not be scared of you have to give in this much of time. So that is one wonderful thing which I have learned. And second, Venkat is working in area which is very challenging. Hats off to Venkat, and he's doing a very good job. And the way people are admiring is absolutely wonderful. So good work, Venkat, there. And because he's the master in his trade, he needs no introduction in Kanpur and in Delhi and in academic circles. Dr. Shefali, thank you very much for being there. See, I learned something from you today. Every day, that's why I said a dynamic lady with a great interest in oncology. Thank you very much for being
We
there.
have always learned from you, sir. That is
Yeah.
no surprise. Okay.
Mm.
Thank you.
Thank you. Thank you very much. Thank you, Dr.
Thank
Vikas.
you, moderator and panelists. So, moving ahead for the next
Last,
session, and this session is sponsored by Glandmark,
so
and talking about immuno-oncology in motion. This, so it's over to Dr. Sumit sir.
yeah, I think this is the last part which I have to do. So basically, sharing my slide, it is on the tislelizumab. So permission to share my screen. Don't be scared by the number of slides. So this is the last part of the session sponsored by Glenmark. So we are talking about a new drug which holds a lot of promise, both in terms of affordability and the results. So we are talking about tislelizumab. Its promise for esophageal cancer and other cancers. So basically, we have about 11 PD-1, PD-L1 agents which are approved now as of today. So it started all in 2014 with melanoma. People initially were skeptical, and now we definitely have these drugs on the board, and they are here to stay in one form or the other or in different combinations. So Tisli is basically a humanized IgG4 monoclonal antibody. So it is different from uh, Nivo and Pembro. So it blocks PDL1 and PDL2 both to PD1. It is differentiated by its unique binding epitopes, binding kinetics, and distinctive binding orientation to PD1. So recommended dose is same 200 milligram administered every 3 weeks till progression. So it has been developed as monotherapy in combination for solid tumor and hematological cancers. So it has a robust clinical trials to support its use. So it has a broad global acceptance is there, has been approved in number of indications across the globe. So we have phase 2 and phase 3 studies in non-small cell lung cancer and esophageal squamous cell cancer. So basically the data is robust and there are a lot of studies to support its use. So basically talking about the TISLI, as I said earlier, it has a distinctive binding orientation to PD-1. So the binding orientation of PD-1 differs from that of Pembro and Nivo, and as well as the binding kinetics, they differ. So PD-1, when TISLI binds, it largely overlaps and covers almost PD-1, PDL-1 covers more interaction is close by more than 99%, whereas in Pembro and Nivo, this blockage is about 80%. And it has more potency to bind there. So this we all know how it works. So it basically in preclinical models, the TISLI has demonstrated very high target affinity and also slow dissociation from the receptor. So its half-life is also 30 to 80-fold longer than that of Pembro and Nivo respectively. So, and it works at the lower uh, MIC. So as compared to the other two, maybe that is the reason it is working well. So if we talk about the data, so TISLI plus chemotherapy for advanced or metastatic esophageal squamous cell cancer comes from Rational 306. Basically, it was a global study done in 16 countries in 4 different geographic areas. So it was a randomized, double-blind, parallel, placebo-controlled phase 3 study. We had platinum plus fluoropyrimidine in one arm and platinum plus paclitaxel in the other arm. So the stratification was done by PDL1 status. So again, as Shifali mentioned earlier, so here also the TAP score was used. And primary endpoint was OS in all the intent to treat patients. So clearly here we can see there was 34% reduction in risk of death and there was delta of 6.6 months. So TISLI, it was a statistically significant. The primary endpoint was met. So median OS was 17.2 versus 10.6, increment of about 6 months time, which is quite impressive. Then again, talking about the duration of response, it was there. It led to more durable responses, and if the patients responded, they were likely to respond for longer duration of time. Whenever we talk about the side effects like EP, we are scared. Here, there were no new safety signals, and whatever we see in the routine practice, they are there. So though we should not be doing the cross-trial comparison, this is just a relative chart to see how TISLI compares with the other in terms of the median OS. So the median OS was about 17.2 as compared to 10.6. Across, it has been the same 10, 11, 10, 11. And with addition of IOs, it has increased to 4 to 6 months time period. And response rate again are impressive. Highest response rates after Tori, another Chinese molecule, which was there. So for the advanced and metastatic second in second line setting was rational 302. So again, so we have something called network meta-analysis. So network meta-analysis basically is basically when we don't have direct head-to-head comparisons, we do it in indirect way. So the statistical method is known as network meta-analysis. So first line, we know it was compared, the 3 different studies were compared. So OS advantage was shown in comparison in network meta-analysis, showing a hazard ratio of 0.66, as which was quite impressive again. So PFS again favoring TIS plus CT in comparison to the other 2 IOs which are there and approved. And objective response again impressive. It was there to the tune of 87%. So grade 3 side effects were there, but they were similar as compared to the other 2 approved IUs. So conclusion of this was TISLI plus chemotherapy has the highest ranked anti-PD-1 agent for OS PFS, and in terms of toxicity, it was quite favorable. So this is the drug to stay there. So coming to the second line, so again the same thing here, the treatment was continued till progression. The Tisli was compared with the physician's choice drug, either it was paclitaxel or docetaxel or irinotecan. So the primary endpoint was OS in randomized patients. Key secondary endpoints were OS in patients with TAP score of more than 10%, and PFS, the overall response rate, was the secondary endpoints. If we talk about the efficacy, there was 30% reduction in the risk when used in the second line. And there was again additional gain of 2.3 months. And so if the patients have TAP score of more than 10%, they are likely to gain better. So there was 46% reduction in risk of death, and there was gain of 3.5 months. So more the TAP positivity, the likelihood of benefit was more. So again, if we look closely, there's the curves, they have started to separate approximately 3 months after, and it was associated with greater overall response rates of 52% as compared to chemotherapy alone, almost double that of chemotherapy. And again, if the responses we look at, the responses were double and 4 as compared to 7.11. So impressive results there in the second line also. So again, demonstrated tolerable safety profile as compared with the chemotherapy in the overall population with lower grades of uh, treatment emergent side effects. So if we talk about, again, we should not be doing the cross trial comparison, but here is the data. So Rational 302, we have a similar kind of OS benefit as compared to the other two approved drugs. So coming to the gastric cancer, in gastric cancer, we have rational 305, in which the Tisli plus chemotherapy versus placebo for advanced or metastatic in first line was compared. So Tisli plus Xelox or 5-FU cisplatin was used here as compared to the without this drug, and treatment was continued till unacceptable toxicity or disease progression. And the primary endpoint was OS in PDL1 positive patients. So again, we'll skip this. We'll look at the data at 3 years follow-up. In all the patients and the pre-specified PDL1 TAP score cutoffs, OS was improved with Tisli plus chemo as compared with chemotherapy alone. So median OS was 15 months, hazard ratio of 0.79, favoring the Tisli combination. We look at the PFS. Again, the PFS was favored in the TIS plus chemotherapy arm. The tumor overall responses again was quite significant. It was there in close to 50%, 47.3% patient, and with responding patient, median duration of response was 8.6 months. So if we talk about the side effects, the side effects were like tolerable and no new safety signals. So again, in first line, OS seems to be better with Tesli than other PDL1 inhibitors. So 16.4 versus 12.8 versus 15.7 and 14.4 in other. So again, if we do network meta-analysis, as we don't have any head-to-head trials. So this was compared with Attraction 4 Part 2, Checkmate 649, Keynote 062, and Keynote 859. So again, Tesli plus CT performed similarly to that of Pembro plus chemo and Nivo plus chemo, with no significant differences were observed. So similarly for PFS, it was comparable as compared to two other drugs. And in terms of ORR, it's performed similarly with no significant differences. So again, side effects were not much. So conclusions were it had comparable efficacy across OS, PFS, and overall response rates as compared to Nivo and Pembro plus chemotherapy. So in the first line, esophageal squamous cell cancer, Tisli plus chemotherapy demonstrated a statistically significant and clinically meaningful improvement in survival and tumor progression with the better tumor responses as compared to chemotherapy alone. So TAP score, we know TAP is the tumor area positivity score, and it is more or less similar. So at lesser values of CPS, again, the concordance was much higher. So this was across all the studies, whether it was rational 306, rational 302, or it was rational 305. So concordance rate was quite high in all between CPS and TAP score. So if we look at the guidelines, so guidelines say we can use it in esophageal cancer. It is a category 1 recommendation. There in first line in combination with 5-FU plus oxaliplatin or cisplatin. In those patients who have PDL1 CPS score of more than 1. So in HCC, so it is again a category 1 recommendation as monotherapy. And what Dr. Venkat showed, the results are there if we combine it with lenvatinib. So again, nasopharyngeal cancer, where we have toripalimab in that domain. So Tisli is also there, but it is category 2B recommendation there, and category 1 recommendation in gastric cancer in combination with 5-FU plus oxaliplatin or cisplatin. So in concluding, so basically it is a different kind of IO drug, and it has demonstrated high target affinity and slow dissociation with the longer half-life. So probably that is where it is making a difference. And in the lung, small cell lung, non-small cell lung cancer and esophageal squamous cell cancer, so there is robust data to support its use, and there is data. And in India, so Tesla is approved in India in second line esophageal squamous cell cancer and in first line and second line squamous and non-small cell lung cancer. So with this, I'll stop here. If you have any questions, I'll be happy to take it.
So, sir, thank you so much. So, is there no questions? So, moving ahead for the closing remarks, sir.
So I thank all the eminent faculties who joined today. Special thanks to Dr. Vikas, Dr. Shefali, Dr. Venkat, Dr. Nikhil, and Dr. Rajiv Seti who joined us. And thank you very much for being there. And thank you, Horizon, for giving us this platform to interact. By learning, we dissect data, which helps us in learning and putting the data which we generate in the Western world, how to incorporate into our set of patients. Thank you again. Good night.
Okay, thank you so much, sir. And thank you for the pharma uh, companies to participate for for this
At the
event.
end, definitely, I want to thank all the sponsors who have made this possible. Thank you, Merck, Glenmark, Sun, and Astra for giving us this opportunity to interact. Thank you very
And
much.
BMS also, sir.
Thank you.
Thank you so much. So, thank you, Yash, for the support, and thank tech support for the execute. It's very well. So, thank you. Good night, everyone. So, tech support, can you please